Good afternoon, everyone. My name's Stephen Scott. I'm from the New South Wales Ministry of Health Mental Health Branch, and welcome to this webinar on the Zero Suicides in Care initiative, and particularly the SafeSide suicide risk formulation training that is connected to the initiative. I'd like to start by acknowledging the traditional owners of the land that we're meeting on, the Gadigal people of the Eora Nation, and paying my respects to the elders past and present. I'll also acknowledge the lived experience of people with mental illness or with lived experience of suicide who are watching this webinar today, and thank you for your interest and contribution to suicide prevention and mental health. For all of the viewers of this webinar, you can ask questions throughout this webinar using the blue hand icon that's on your screen. So please send questions in and we will respond to them as best we can. And also for any of your colleagues that are not able to view this webinar today, a copy will be made available on the New South Wales Health website in the near future. The Zero Suicides in Care initiative is one of the Towards Zero Suicides initiatives that is supporting the Premier's priority to reduce the suicide rate in New South Wales by 20% by 2023. And these initiatives address priorities under the strategic framework for suicide prevention in New South Wales, and will be implemented in every local health district in New South Wales over the next 3 years. The Zero Suicides in Care initiative is a change management and quality improvement initiative to prioritise suicide prevention within the mental health system, both in acute and community care settings, and it responds to the greatly elevated risk for suicide among people with severe mental illnesses. The Zero Suicides in Care initiative will have many different components, but one of the key components will be most essentially an updating of our workforce's suicide prevention risk skills and response to people at risk of suicide within our system, which is what brings us to this webinar today, and particularly to the SafeSide approach, which has been advanced by Dr. Tony Pisani and Ms. Kristina Mossgraber from the United States. Both Tony and Kristina have worked with New South Wales Health over this year in two separate engagements, one in April and then another just in this last week, presenting workshops on the SafeSide approach in Queanbeyan, Broken Hill, twice in Sydney, and also in Wollongong and Newcastle earlier this year as well. So I'll now introduce Tony and Kristina, and we'll just proceed over the next hour with some quite informal discussion. As I mentioned, you are very welcome to submit questions throughout the webinar, and we will respond to them, and you can use the blue hand icon for that purpose. So Tony Pisani is an international leader in suicide prevention education. He is on the faculty of the University of Rochester Centre for the Study and Prevention of Suicide and the founder of SafeSide Prevention. Dr. Pisani has published numerous academic papers and served on national work groups, including panels for Joint Commission and the Workforce Preparedness Task Force of the National Action Alliance for Suicide Prevention, which authored the current US National Suicide Prevention Strategy. And Ms. Kristina Mossgraber is an advocate for recovery-oriented behavioural health care. A suicide attempt survivor, Kristina devotes herself to improving care for others who suffer as she did. She is Director of Education and Community Outreach for the Rochester chapter of the National Alliance for Mental Illness, and provides lived experience expertise to all programs provided by SafeSide Prevention. So welcome to Tony and Kristina.
Thank you so much.
We might just start by asking a very broad question to request that you provide a summary of the SafeSide framework.
Yeah. Well, we're really glad to be here. Every problem becomes more manageable if you have a framework for understanding it. And what we've been developing over the last number of years is an approach to summarizing what is now the set of best practices in suicide prevention that falls under the framework of zero suicide. Maybe we can each share a little how we came to this work. Do you want to share, Kristina?
Yeah. So 5 years ago, I almost lost my life to suicide. Like many people, I had struggled for a long time and wasn't really sure how to get help or what to do. And so after I spent a month in the hospital at the end of 2014, I embarked on the very difficult journey of recovery, which is the hardest job I've ever had, but the best job I've ever had. And in that process, I made a commitment to myself that I was going to take this experience and do something positive with it for other people. I wasn't quite sure how that was going to look or how that was going to, kind of tease out, but I started volunteering and getting stronger and working again and getting stronger and joined a board at our medical center and getting stronger. And that's where I had the great privilege of meeting Tony through a mutual friend and joining the SafeSide prevention team. So,
yeah, really my privilege actually, because I came to suicide prevention also through some difficult circumstances. There was a service that I was part of, and we lost 2 people to suicide in the course of 3 months, which was very traumatic. The second of those suicides was also especially difficult for me personally and professionally because in my involvement, I had made a couple of errors and missed some things that weren't what led to the person's death, but did lead to, a lot of self-blame, as well as, at that time, it was a time in suicide prevention where, there could be a lot of blame and scrutiny on people doing the work as well. And I think that's something that's changing. And I know that, just spending time here in New South Wales, I know that that's a very important commitment to create a culture where people feel supported. And so that's extremely important to me too. So out of the midst of that, I began learning what I could about suicide prevention and care settings, the real dilemmas that there are, because it's always one thing to sort of say, oh, here's what would be good practice, but being really in it is another thing. And so out of that, we developed this framework that has basically these 4 core tasks that we all engage in. The first is to form good connections, and then to have assessments that are going to actually be actionable and engage a person at risk, to respond and know what our responses need to be, and then to extend our care out, beyond the individual, beyond the walls of any facility, and beyond any one episode of care. So that's the framework that we work from, and have been privileged to continue this learning process by sharing what we learn, and then learning more, sharing that, because really nobody can call themselves an expert in suicide prevention. As long as this is a problem, we're all learning.
That's a really good point. One of the foundations, I guess, of SafeSide is this shift from the stratified risk or approach to risk that has characterised suicide prevention historically, and really up until very recent times. And you instead use a language of risk formulation, which represents quite a new and more innovative direction in the field. Could you talk a little more about what that shift means and why this new approach is so important?
Sure, maybe we can share some of that. For a long time in our field, we've had trouble knowing how to synthesize the information that we gather. I think people are very good at making connections and gathering information, but how do we bring it together? So, we've often defaulted to this idea of, saying somebody's at low risk or high risk or moderately low, high, moderate, low. And I think all of us who have been working in the field sort of know that there's problems with that, but we haven't really necessarily had an alternative. And so some colleagues of mine, along with lots of input from people who work with youth, who work with adults, older adults, community settings, develop this prevention-oriented risk formulation. And the idea is to really shift our mindsets from thinking about risk as something that we're engaging in to predict, who is it that's going to be engaging in suicide behavior. So rather, the purpose is not prediction, it's planning. And once you sort of shift that mindset, it really kind of changes things a lot. One part of this framework involves not only summarizing risk in a way that's more contextualized, because when you think about it, risk compared to who? Risk compared to when? So we try to contextualize risk in the person's setting and in the relation to their life, but then also identify, as part of our formulation, what might change things quickly.
So the part of the risk formulation that Tony's just mentioning is something that actually happens to be my favorite part, which is something called Foreseeable Changes. And that is identifying two things that, if they happen in a person's life, could send them into a really bad place, really, really quickly. And when I first was learning about the model from Tony, that really resonated with me because I have fantastic safety plans, I have things in place, but I had never thought about it in that context. Like, if something happened, what would something that would just really, like, all those plans would go out the window, where if that happened in my life, it could just be a oh no moment, immediately, where I would need someone to step in and to help me, get through that and navigate that. So,
yeah. And so a risk formulation is identifying, if we have these sort of four concepts. First, risk status. That's risk compared to who? This person, compared to others who are typically, supported in our environment, where does the person's risk fall, and then why? And the idea there is just exposing our thinking, making this transparent so that we can communicate across a team, rather than just saying this person's at high risk. This is how they match within their setting. Risk state, which says risk compared to when. This person, since they entered our service, maybe their risk status might be still higher than other people because of all different things that have happened in their life. But maybe their risk state has decreased. We want to be able to account for that too. Identifying available resources, and as Kristina said, these foreseeable changes.
One of the other quite appealing principles, I think, of the SafeSide approach is this concept of more than safety, which I've seen on your slides and heard you talk about as well. Could you talk a little about how that's made meaningful in practice and how you address that through the framework?
For me personally, that is such an important part of the framework and of our mission and our work, because I was in the hospital for a month and I heard a lot about safety, which is integral, right? We have to keep people safe and we have to, manage the environments and all those things that go into that. But there's more than safety in that. We need to keep you safe so that, I think of it that way. It's the safe so that, in my case, I was 34 and I thought my life was over, that this was it. And I just needed to stay safe in the hospital, but safe so that you can go home.
Right.
Safe so that I could see my dog again, even just small things, safe so you can go home and rebuild your life. And again, safety is so integral, but it helps shift the thinking to the safety is more than just that moment in time, keeping somebody in that episode safe.
And in terms of how that shows up, this is why we call it a recovery-oriented approach to suicide prevention. And I think this fits in very well with other movements that are already taking place here in Australia and even in New South Wales. I don't think it's really a new concept, but I think it's something that we can all unite around, the idea that we're aiming higher than just safety or just stopping suicide. Well, we want, yes, of course, but we want people to flourish. And I think when you approach the work and think about, okay, when we're working with people with suicide concerns, there's sort of a built-in opportunity for disconnect to happen, because, we're about preventing suicide. We're going to stop suicide, so for us, suicide is a problem. But often for the person who's struggling, suicide is a potential solution to a pain problem and
right.
a whole set of. So when we have these different perspectives, for us, suicide's a problem. The other person's a potential solution. We have to figure out a way of bridging that. And that's, I think, where this shows up in the work is that, well, how do you bridge that? Well, one of the ways you bridge that is by having that common goal of feeling better, achieving what the person wants to achieve. In a sense, you could think of that the suicidal desire, we actually have a lot in common with the desire that it has, which is to just feel better, to escape the difficult feelings and be in a better place. And that's where we can both collaborate around.
That's a fascinating insight you're demonstrating there into some of the challenges, I think, in clinical interests or clinical objectives and suicidal thinking. And it's very interesting to hear you talk about a meeting point or a point at which you think these things can intersect. I wanted to ask you, Kristina, a little bit more about how you think this approach is of benefit to people with lived experience as consumers of mental health services. What kinds of changes can this type of approach bring about for people with mental illness who are at risk of suicide?
I think that's such a great question. I think that this model is just so beneficial. And the first thing I'm going to say is just that, and it makes sense to me. I'm not a trained mental health clinician, but even, the first time I read it, I could see myself in the model, and I could see how my care could have been different with a model such as the SafeSide prevention model, starting with the first concept in the assess where you're collecting the information. It's strengths-based. So the first piece of information that's being collected is strengths and protective factors, and it's all about what makes the person who they are. And I remember when I was in that place, I didn't think I had anything good to offer. I didn't think I had any strengths or anything like that. And so even when we deliver the workshop and we practice, hearing it as a strength-based, beginning to the recovery journey is so powerful. And it creates an opportunity for transparency. It really creates an opportunity for patients and consumers and caregivers and clinicians to use a common language and talk to each other. I often felt that there was, they would all come in and talk to me, and then there was some magic that happened in the conference room, and then I wasn't going home, or they were going to change my medication, or something was going to happen, but I had no idea why.
Right.
And using this, it really changes the power balance. And to me, it creates a sense of respect. It creates respect and dignity for the person's experience and the person's story and who they are versus, we talk to you and we go make some decisions in a conference room and that's that.
Right.
So it's very powerful to me as a former patient, thinking about how my care would have been different. I had amazing care, but it could have been a whole different trajectory just out of the gate, talking about it the way that the model talks about prevention. Recovery.
So, Kristina, you were picking up there on the first of, I believe it's 4 steps in the framework, the first being assess. Could you talk a little bit more, both of you, about those steps, the first one as well as the subsequent steps as well, just so we start to flesh out a little bit of detail about what this framework really consists of.
So we're at a little bit of a disadvantage in not being able to sort of show this framework that we're talking so much about.
I should hold
especially since we're talking about, something happening behind the curtain. And then so, in a sense, we'll hope that we can have lots of opportunities to delve into it more. But yeah, so connect, assess, respond, and extend. So, we've talked a little bit about connecting around the common goal of recovery and committing to that goal with people and with our teams, having a prevention-oriented assessment that is actionable and anchored in a context. And then the other two are respond and extend. And respond, I can tell you, working with people in a variety of different settings, one kind of anxiety point for me is, especially when it seems like things are sort of deteriorating for somebody, is like, what am I supposed to do? I mean, what is my job? And so you start to kind of have a flurry of activity, and for me, it's been so helpful to just have a framework that tells me, there's 4 things you got to cover. First, try to address the things that are driving the suicide concerns.
Right.
So that's one. Second, make solid plans for the person's safety and sustenance. And then third, think about how to support the person in their least restrictive environment. How to think through when more support is needed or higher levels of care, but really aiming for that least restrictive environment. What are we doing to adjust our level of contact and observation? And then fourth is, am I talking about it with other people on my team? Address the drivers, make good plans, support the person in the community, talk with a team. And once I know, okay, that's what my job is, then I can kind of relax a little and then do the work that is really so critical if we're going to save lives, which is to really care and not be anxious or defensive, but just be there for a person. And so when you know that what your job is, then it frees you up to then do the human work that is most essential.
Working in public health, I know you'll both be very familiar with the need for us to refer to an evidence base and to ensure that what we're doing is reflected in the literature and in what we know to be best practice. Can you refer to the evidence base that has led to the development of SafeSide and also to the evaluation evidence for the model as well?
Sure. So the SafeSide framework is really a map of best practices. Each of those practices that are sort of on the map have their own literature base. And so in some ways we're mapping territory that's been walked. And just bringing it together in a way that teams can share it in common with a common language and a common set of practices. So there's that literature. The training itself that we tested in 2012 and published a paper about it. I think we were the first suicide prevention training that showed objectively rated changes in people's assessments. So we had trained coders looking at people's assessments and were able to show objectively rated differences. And from that training, though, and from 2012 to now, we've only kind of gone up, which was, first of all, involving Kristina. That was a training that didn't have a person with lived experience perspective in it. We also added a lot more video demonstration. We realized that, just hearing concepts or talking, you can only go so far. We need to really see these things in action and then engage each other in discussing how does that apply in my setting. So there's that evaluation. We're also engaged in multiple other evaluations in different places. There's a large youth services organization that has also conducted an evaluation. And with respect to our training, there was also evaluation done here in New South Wales. And we were really very pleased to see that people found that very relevant to their work and setting. In fact, some of the measures that we've used in other studies, the reaction was even stronger here in New South Wales. So we were pleased about that. And there's ongoing research at the University of Otago in New Zealand, and we've been very involved in zero suicide on the Gold Coast. Right. And there's been a lot of evaluation around fidelity to the framework there, as well as some really encouraging reductions in adverse events.
You've touched on a whole number of points that I want to ask additional questions about, which is great. Starting though, I think with the lived experience component of the training that you've been delivering, do you want to, firstly, Tony, talk a little bit more about the way that came about in the first place? Because obviously the involvement of people with lived experience really represents a sea change in the way that we do suicide prevention and mental health care over the last decade or so. And then additionally, Kristina, if you could also talk about what your role is in the training and what it is that you bring practically to the training.
Yeah, and beyond the training too. Okay, so a couple of years ago, I was speaking to a group of people. I'd been, sort of brought to an area to speak about suicide prevention, and I was strongly and passionately advocating for collaboration with people with lived experience, that everything we do needs to be done together. And I realized I was standing up there by myself. So I had this sort of moment and tried not to be too distracted by it for the rest of the time I was speaking. Once you start thinking about that, as the whole rest of the time,
thinking, should I really be doing this?
Yeah, should I really be even here? That's difficult to go on for the rest of the day like that. So I got to work on it after that, so I was really very actively seeking for a number of months, somebody who would be, really a very strong collaborator, who could not only share in co-training, but also provide active input into our programs, and who would also be able to share honestly with me places where maybe our approach didn't fit. And so I was very grateful to find Kristina, and who has been just the ideal collaborator, and who's now leading lived experience for us, and you can share about your role in the training, and as well as kind of our expansion of wanting to involve other people in each of the localities that we're working with. So really would be part of a team as well. So do you want to share your role in the training?
Yeah. So I mean, everything we do, we do together. Really, it truly is a partnership with Tony and with the rest of our team. When we're creating new materials, I always, review the scripts and offer input. That was actually, I remember when I first started, that was kind of the first thing. We were developing all these things, and I would read them, and I was like, ooh, if somebody said that to me, I would walk right away. And so, we made changes, and as we started to work more together, though, I felt heard, and I was just so grateful to, really, because, you start anything new and you're like, okay, is this really where I need and want to be? And as we got to do more and started doing more workshops, I was like, yes, this is definitely, walking the walk of it. And so I've, provide, again, advisement on that, and we teach everything together locally and globally. And our goal and our mission right now is to build a team, because there are so many more voices than just my voice that represents lived experience, and lived experience from not only someone who's struggled with suicide concerns, but from family members and from loss survivors, and that whole collective voice in different cultures and different areas, and all those voices that make up the changes that are going to happen in suicide prevention and bereavement and all the other pieces that come with it. Because I think it's a great opportunity for a big culture change in suicide prevention and loss. So.
Can I ask a few questions then about the delivery of the training, if you can think of that in its broadest sense?
We call it a learning program.
Right, a learning program, yes, because there is a number of different components or means that you are delivering this. We've obviously had now 6 workshops in New South Wales this year, but physical in-person workshops are not the only component of the learning program. Can you help us explore a little bit of those other methods that you're using and how they kind of fit together as an integrated whole?
Sure. Yeah, take that. Yeah, as you said, we've had really rich experiences, and we love having those in-person trainings. Spending a day with a group, and we learn a lot that way as well. But yeah, there are limitations to that. And at one point, I sort of had a bit of a moment of truth about that too. I think, which was that there's a few existing models for training people, and you could do online learning, but many times that's something that happens on one corner of your screen while you do other things, and we didn't want suicide prevention to be that way. And even us going to someplace, I think it's a very valuable thing, but there isn't always follow up to that. And I started to really feel convinced that this has to be an ongoing thing. If we're really going to have the kinds of goals like the Premier has set, it's not going to be a one and done thing. Yeah. So what we have developed is something that we call in-place learning, which starts with online learning you do as a group. So rather than 60 people coming into a room and us at the front of the room, we really want to see teams and groups around a table, working through video-based materials where Kristina and I and others teach core concepts, demonstrate those in videos like I was describing before, and then having a chance to really talk about and practice those things and assess how does that fit with the population that we're working with in our location and our roles, because there's so many different really important roles, from people who are in very much clinical trained mental health professionals, but also there's people who are in other supportive roles, case management roles, peer specialists, who are all important parts of a team. And so if they can all take in some material that's online and available when it works in their schedule, but then have a chance to engage together with it. That's kind of the core part of our and that launches the learning program. We follow that up with monthly opportunities to interact with us and other groups around the world who are kind of engaging with a similar framework through sort of a video-based learning collaborative type opportunity. We call it virtual office hours. And then in an ongoing way, having quick, sort of 5-minute refreshers that keep us all thinking as we get frequently asked questions or as things change in the field. This field is really changing rapidly in terms of what does it really mean to do the best kind of care we can. And so it's been really encouraging to see people's responses to that. Most people in the mental health field really want to engage. And we have found, certainly here, incredible amounts of clinical wisdom and skill. And so it's been very fluid and engaging to then bring people together and to go from there. So yeah, that's how we're approaching it. And so we aim for the kind of workshops that we've done to really be a kind of a first step in engaging.
It's a really different approach and a much more sustainable approach, I think, than just the fly-in, fly-out approach. And, as you say, with these ambitious goals that we have, and because of the challenge and complexity that suicide represents for the whole community, these kinds of approaches that just skim across the surface are not going to suffice.
Yeah. And, we know that change happens in groups.
Right.
And to me, that's critical. I don't think people need to talk with us as much as they need to talk with each other. I think that's really where the change happens. There's so much expertise in every team. And we're aiming to, present some things that will, hopefully stimulate and maybe, advance the conversation. But really, it's the expertise of the team sharing with each other, having a moment in our very busy schedules to step back and say, how are we doing this? How are we connecting, assessing, responding, extending the impact of what we do? How are we doing that with the people that we serve?
It really addresses a whole number of issues, I think, that we have around responding to the risk of suicide in the care system, whether that be the community or in inpatient settings where we need this consistency of approach. We do need teams to be engaged rather than just, engaged collectively rather than just individual approaches taking place. And I feel as though this links back to some of the earlier remarks you made about addressing cultures of blame and taking more of a systems view rather than an individual clinician's fault or flaws being the way that we should be analysing and responding to this issue.
Yeah, I think that has for a long time sort of been the way we've sort of thought about it, but I think that is changing. This kind of brings up one of the, I think sometimes the concerns people have with the words zero suicide. It's funny because, people might think, oh, well, does that mean we're going to be blamed if there is one? And it's actually the exact opposite. The idea behind zero suicide is that we create systems of support for us to do this work, and that it is the whole system's job. And so the taking it out of, so it's not all up to me, is actually a tremendous relief. And I know that there's a great deal of work going on here too about supporting that kind of a culture where people can feel safe to do this really, really hard work.
That's right. Now, we are receiving quite a lot of questions here, so thank you to everyone that's been sending these in.
Game on.
But we definitely want to respond to as many of them as possible. So a first question here, we have downloaded the overview document, which is available on the webinar, and that consists of some of the diagrams that are included in some of your presentations and promotional material, and this is being looked at while we're presenting. So could you explain where in the framework would you incorporate a mental health status assessment or a mental status assessment? Would this fit in the assess?
Oh, yes. Yeah. So I think the materials that you have, the framework is pretty tiny, but if you have it on your computer and can zoom it in, you can see that on the left side after connect, there are, maybe I won't put my hand right in front of your face. There's two circles, one that involves the sort of more enduring factors, and then the other, which is more dynamic factors. Right here is symptoms, suffering, and recent changes. That's where we track mental status. So we kind of put it in the context of other factors that provide the sort of the setting in which your risk assessment occurs, but mental status happens under that sort of category in the collection of data that informs your formulation.
Okay, thank you for clarifying that. There's a very interesting question here regarding the tailoring of the training to diverse contexts. So obviously you're working in a number of countries now with some very diverse and different cultural settings. Even within New South Wales, I think you've probably seen a number of diverse and different settings. And so the question is about the tailoring to the Australian context, but perhaps you could also talk more generally about how you're responding to these different settings that you're providing a service to.
Yeah. So I'll share our approach to kind of cultural responsiveness. So first of all, the foundation is kind of what I described a few moments ago, which is that a key part of the learning is what the group is doing with the material. So throughout our video-based training, it constantly reminds the group to discuss how does that apply and be adapted with the cultures that you're serving. So that's one part, is the way it's sort of built in. But then we also have a kind of a stepwise approach to our kind of engagement and responsiveness with the specific cultures that we're serving. And our model for this kind of grew out of our work in New Zealand. We work with one of the sort of their equivalent of an LHD, a DHB. So the first step is getting feedback. And so in that example, we had some good feedback from Maori mental health groups that were engaging with the training, and then actually updating the training based on that. So as a small example, there was a clear bit of feedback that in this approach there needed to be lots of time provided early on for points of connection. And so we adjusted the training based on that. And it turns out that actually helps everybody. So that's the first step, is gathering feedback. We have a very active evaluation process, engaging with different groups, getting feedback and adjusting the training. The next level of that is, Kristina, you mentioned it already, which is that we want to engage people in each of the countries that we're working in to work with us. So the next step after that is, especially our first next step, is working with persons with lived experience here in Australia. And the goal there would be to actually create new materials that will, as people are getting experience with the framework, create new materials, both teaching and video demonstrations. And so actually that's the step that we're at now with our New Zealand colleagues, which is that we're in an engagement. Of course, these things, especially around engaging with other cultures, it needs to be a careful and thoughtful, with lots of listening and back and forth. But we're in that big stages where the goal there is to create some video demonstrations that with New Zealanders and then have some modules that are teaching modules that are actually co-taught with people. So that's where the vision is and the steps that we're taking there, and that will be our kind of approach here as well. Thankfully we have some good initial feedback, both from the evaluation here in New South Wales, but also from the implementation in Queensland. So we have now 3 years worth of feedback there about the relevance. And then we're also engaging in a nationwide effort here with the Department of Veteran Affairs. And so we'll be gathering, that's another subculture, really.
Yes.
Or multiple, probably, subcultures. And so we'll be learning additionally from there. We have experience with veterans in the U.S., and we're finding quite a lot of commonality, actually. But where there are differences, we'll be making adjustments and creating new materials.
Okay, thank you for that. Now, we've got a couple of questions which are related, I think. Firstly, can non-clinicians working in mental health take the SafeSide training? And quite specifically, do you also train mental health peer support workers with lived experience? So I'm sure there's plenty to say about this.
Could you tell it? I got excited. Short answer being yes. And that's, again, part of the beauty of the model is that even, non-clinicians, if you will, I don't like saying non-professionals because we're all professionals working in this. Peers are professionals. So anyone, working in the field, there's parts where everyone can contribute. I guess from my perspective, because we've been thinking a lot about how to integrate into our training, where peers can come in. And a big part of where I see that is when you're collecting the data. in the beginning of the assess model, because a lot of times people with lived experience will only tell a peer things.
Right.
Now, obviously, there's boundaries and there's things that have to be, discussed and clarified and proper supervision and all the things that we all need. But there's a very, very integral role for peer workers and for non-clinicians, if you will. Again, I can tell you that my best connections were with the techs. The people that I worked with in the hospital. We didn't have peers on the inpatient unit that I was on, but there was technicians that came in and, did all kinds of interviews. And I talked with them the most. And so they would also fall kind of in that realm of, non-clinician, but frontline people. So.
Yeah, we aim for teams to be on the same page and with sharing a common framework and language, and so every person is valuable in that. And so, yes, it is designed. Now, our training does also include an additional sort of module for people who are in more clinical type roles, people who are the ones who sign their name at the bottom of the page. And so there might need to be some additional work for that subset of the team. But most of our training really is designed for the whole
everybody.
team.
Yeah.
Okay, thank you for addressing those points. There's also a group of questions that relate to the in-place learning or the office hours, the various online aspects of SafeSide. So people are just wanting a few more details, I think, about how that all works. So I'll just read out these few questions and maybe you can...
Yeah, like as a group, we'll try to hit
we'll get them.
Yeah, so can you describe what kind of support is offered over online office hours? Can our team join you as a group to ask questions? I assume that's rather than individually. And as a service, how do we select people to run our in-place learning? I think this is a really interesting and important question. And do those staff members require training to run the in-place learning sessions separately?
Yeah. Those are really great questions.
Yes.
Okay, so should we take them in order? Okay, I think
sure.
the first
Okay.
one is what's office hours like, kind of. Yeah, do you want to hit that one and then I can grab the others?
So office hours are they're offered monthly, and they're a half hour with Tony and I and other members of our team. And we encourage people to bring their questions or their thoughts or their experiences to us. If there aren't any at the beginning, we do have an agenda that we've created with feedback we've received and things like that to kind of get the conversation going. But it's a great opportunity to learn from people around the world. We had a great office hours, our last one, where someone asked about why risk was not, why wasn't called hope status and hope state, which provoked an amazing conversation and got a lot of us thinking and experience sharing. So we're there to answer questions and to offer support and feedback.
Yeah, and also it holds us accountable because if we're teaching something and you're, working on it as a team and you find things don't fit, hey, we are always just a couple of weeks away from asking that question. And it's also what helps us to improve too.
Absolutely.
So that's office hours. I think the other question was about
the in-place learning and particularly training of.
Oh yes, right. So in-place is the idea is that there's a participant facilitator who's really their job is to kind of organize the group to get together, make sure that there's a place to view the materials with good sound and good visuals to advance the videos and keep the group within the time limits that we've provided for discussion. And that's actually the hardest part of it. These topics tend to really get people going, and which is fine. There have been some groups that decided, well, we're just going to take the full day so we can have more discussion time than you leave. Right. We've made it to be sensitive to the, all the time demands there are, and the fact that it's, there's people waiting to see. We've kept it, contained to a half of a day, 3 to 4 hours, 3 hours for the full group, 4 hours for the additional clinician part. But yeah, and so there's a 5-minute video orientation. You can find it actually on our YouTube channel. If you were to if you put into YouTube SafeSide prevention facilitator orientation, you'll find it there. It's just sort of 5 minutes that kind of says, here's your role as a facilitator. So it can really be anybody in the group. It doesn't require any special knowledge. It's just more about somebody who has sort of a willing spirit and who can be sort of nudge people along to be like, hey, the timer went off a while ago. Let's keep
Gently.
going. Otherwise it would just take longer.
And so those people have instructions available to them, but
Yeah.
they don't require separate.
No, so there's
training in order
a
to play that role.
one-page facilitator guide that sort of shows you what to do, and this 5-minute video to watch to sort of understand what your role is. But really, that is the whole idea: is that it doesn't, require a big kind of train the trainer effort or any special. It's really because we want teams to be able to kind of say, hey, wow, let's just do this. We can do this in 2 weeks. Let's just block a little time and do it, and really try to have the load be the lift be light, so that the real effort can go into the conversation and the engagement with it.
I just want to go back to office hours for one quick question, because I did hear, can teams participate as a team, or does it have to
That
be
was the other
individual?
one.
The answer is yes, you can as a team, but what I would recommend
do.
personally, and yes, people have, because it is just such half an hour, it's such a short period of time, maybe have just a little pre-discussion of the question or questions you wanted to get across, just again, because we just have that short, precious half an hour. But we'd love to see as many of your team members as possible.
And people can attend. We offer, although it's only half an hour, we offer it because of the different time zones. We offer it more than one time a month, actually. And so, depending upon what time you're wanting to show up,
Time you want to get up.
you could attend more than one if you had additional question. But we offer one during working hours in each of the major time zones we're working with.
Okay, thank you for clarifying those points. There's an interesting question here regarding the framework's integration with technology. Would you recommend safety plans or other aspects of the framework on apps?
So short answer, yes. What the framework is really providing the content of what those practices are, and what are the principles in wanting to, because we're very much about not just what you do, but how you do it. So if you can again zoom in on your framework, when it comes to planning, there's creating safety and contingency plans, really key. And then it extends on to giving input and clear roles for other people. Now the question is how to do that in the best way. How are we going to extend the impact of our safety plans so they're not just a piece of paper? I think that's one of the big challenges we have with an important intervention like that, is that it not just be a piece of paper. So, and not just an app either.
Right.
Because it could easily, just because you put it on your phone doesn't mean the person has really engaged either.
Right.
But anyway, with respect to that specific question, we do think that it's probably the best place for a safety plan is to be on your phone, because that's the one thing everybody usually has with them. And it's also how do you do that with the person, how to engage them, how do you make it as collaborative as possible, knowing that sometimes it's very hard for people to sort of come up with ideas. And it's one of the things we talk about is that let's get real about this. How do you really make it something that matters?
Okay. There was an interesting question we received earlier regarding the applicability of SafeSide outside of the mental health context. And I think that question is possibly open to some interpretation, but I was thinking that it may refer to, for example, settings which aren't necessarily the mental health system, but might be youth services, the justice system, other settings which aren't so health focused specifically.
We have not yet worked in correction systems. I think the framework would be applicable, and certainly we are applying risk formulation to violence risk assessment, and there's actually a module of the
Right.
training about that. We have specific versions of our training that are for primary health care and youth services. And so they are a little bit different from the core behavioral health training, mental health settings. The primary care one is a little bit briefer and has less about sort of risk formulation and more about, there's a big focus on, we wouldn't take out your beloved, foreseeable changes, but we don't get too much into risk status and risk state in a primary health setting. And in youth services, it's really designed towards people who are in, sort of school support roles or those kinds of things. So yeah, we do have particular versions for those.
Okay, thank you for that. Now, there's a couple of final questions here, and we are in our last few minutes, so we will just try to get onto those. And this is probably more a question for me to answer, which is whether New South Wales is adopting the SafeSide framework across all local health districts. So, as I mentioned earlier, we have had Kristina and Tony here twice this year presenting workshops in a number of our local health districts. We're currently working on a longer-term engagement with SafeSide to make a range of the training available, as we've been discussing, not just through those face-to-face workshops, but through the online support as well. As I mentioned at the beginning of the webinar, we do see this shift to a more contemporary risk formulation approach as being quite fundamental to the Zero Suicides in Care initiative and to the effectiveness of a zero suicides healthcare approach in New South Wales. So we are working on bringing that piece of the Zero Suicides healthcare framework into the initiative in New South Wales. So you can certainly stay tuned for more information about that. And just in the last few minutes that we have, there is a really great question here. After the travelling that you have done around our state and also in Queensland and now also in Canberra with your engagement with Veterans Affairs at the Commonwealth level, what do you think are the strengths of the system that we have here to prevent suicides, and really any other impressions that you have gained of our workforce, our system, and the way that we are currently seeking to tackle suicide in New South Wales?
I mean, I have to say, quite honestly, my experiences have been nothing but positive. I feel very inspired that I think that people are really behind this movement. I see a lot of passion and I see a lot of drive and I see a lot of empathy and I see a lot of inclusion too. I've been really honored to see so much inclusion of lived experience and of what everybody brings to the table to make this a reality. Everywhere I've gone, there's been some poignant moment or some conversation that I've had that just has really stuck with me. And I go home from these trips just so inspired again with the work that's being done here, and I know the work that that's to come. And I really truly believe that people are invested in this and that the change is going to happen here.
Yeah, in my mind, Australia is leading the world actually in suicide prevention. So we feel privileged to be part of this, and we're learning at least as much as we're offering. In terms of strengths, I can speak at the system level as well as the clinician level. So there is more, I think, community outreach and focus happening here than almost anywhere. So that's one clear strength. And we have just seen such clinical wisdom. The people that we've worked with here in New South Wales, there's depth here. And so really this is not about bringing brand new skill. It's really about bringing it together.
Yep.
So it's been a pleasure, and there's tremendous strength that would be that we're pleased to be joining up with.
Thank you. Now, we are almost out of time. Given that we have referred quite a bit in the webinar to, I think, a number of different slides or different resource materials that were illustrating some of the points, we may look at publishing those along with the webinar so that those that are viewing this in future and those that have viewed today can refer to those to help fill out some of the details that we were covering. But at this stage, I would just like to thank everyone who has participated in the webinar. I've noticed that a few of you have sent through some more questions, which unfortunately we're not going to quite have time for. But we will review those and provide a response to you either by email or over the New South Wales Health website. So thank you very much for participating today. And Tony and Kristina, thank you both so much for both this webinar, but also all of the work and commitment that you've been giving to us here in New South Wales over this year. We've greatly appreciated your insights and your enthusiasm and your passion for this work. It is quite infectious, and so we look forward to seeing you again soon. And thank you again for everything that you've done over these last few days as well.
Thank you. Thank you,
so
Kristina.
much.
No problem. Okay, well, have a great evening, everyone who has been viewing this webinar. We will be presenting these types of webinars with some regularity with different suicide prevention experts over the coming months. So we very much appreciate your interest and your participation going forward. And for further information on the Towards Zero Suicides initiatives, whether it's Zero Suicides in Care or any of the other work that New South Wales Health is implementing, please go to the New South Wales Health website or feel free to contact any of us at the Ministry of Health to discuss those initiatives at any time. We very much welcome your approach to us. Okay, have a great evening and thank you again.